Thank you. So we're going to start with the second half of this morning, which is the medical assistance in dying MAID conversation. So the purpose of this presentation is not to really get into a lot of the kind of political aspects of MAID, but it's to give you a understanding of where we're at, what the law is, why it was basically presented as it is, what happens in the provinces, and then to give you just a high-level overview of some of the ethical considerations with MAID. So no disclosures. So background, we're going to talk about MAID, the legal frameworks, the WRHA policies, which just WRHA policies basically become very similar policies for prairie mountain health areas, other areas within the province as well. The policies are very similar. And then the development of some of the ethical issues will be the second part. So I'm assuming most of you have heard of MAID at this point. Okay. So this started really in about 2015 with Carter v. Canada. And so the Canadian Supreme Court case challenged whether it was unconstitutional, whether it was criminal to have assisted suicide. And so it struck the criminal code provision that was basic, and it allowed medical assistance in dying. So we're going to talk about the vernacular in a moment of like what is MAID versus euthanasia versus assisted suicide. But essentially that happened in 2015, and then in June of 2016, legislation was passed to allow MAID. So essentially it was deferring the judgment, and we ended up in June of 2016 actually having law now on it. So the definitions, outside of the Canadian context, we talk about euthanasia and physician-assisted suicide. In Canada, we talk about medical aid in dying or medical assistance in dying. And so it's just important to kind of understand the different frameworks here. So under the MAID governance, there's direct administration and there's self-administration. And what that means is direct administration is either a physician or a nurse practitioner, depending on the province, and we'll talk about that in a moment, administers a substance, like an injection, that causes death. Okay? In every other context, that's called euthanasia. Here we call it direct administration. Okay? There are very few countries that actually allow direct administration. The United States, for example, does not allow euthanasia or direct administration. Certain states will do allow self-administration, and we'll talk about that in a second. So self-administration is what everywhere else calls assisted suicide or physician-assisted suicide. And essentially, it is a prescription of a drug or series of drugs that then allows an individual to consume the drugs on their own that results in death. Okay? Now, it's important that they're parsed out because right now we just talk about MAID generally, and it's technically both. And in the province of Manitoba right now, we only do direct administration. We have reserved the option for self-administration, but we have not actually, there's not the framework in place for that. When we talk about the drugs that are actually prescribed, that is then left to the provinces to figure out the types of medications that are then administered. So that's the difference. Now, who actually administers MAID? Right now, it's physicians, nurse practitioners, depending on the province. Pharmacists also have to write the prescriptions. In theory, if we get to more of the self-administration in Manitoba, you would have family members who could also help assist, and then you would have assisting healthcare providers generally. And so this means like social workers, nurses, etc. And we're going to talk about the MAID team that's in the province of Manitoba in a moment because it's a slightly different mechanism. We don't have MAID just at any given hospital. There's a team of professionals who then go visit patients and determine eligibility. And we'll talk about that. So what does eligibility actually mean for MAID? And all of this is Government of Canada information. But you have to be eligible, first off, for health services that are funded by the federal government. So this means that people cannot come to Canada as like medical tourists in order to get MAID. Okay? So we've seen that kind of in the Swiss model where people were going to Switzerland. This is, unless you are a permanent resident, Canadian citizen, have other authorization, and you are ineligible for just our provincial health cards and coverage, you are not eligible. You have to be 18 years of age, and you have to be mentally competent at this point in time. You also have to have something called a grievous or irremediable medical condition. We're going to talk about actually what that means in a moment. And it has to be a voluntary request. It specifically says that it cannot be at the influence of others. And the last aspect is informed consent. So there is a consent process. So this is eligibility for medical assistance in dying. So what does grievous and irremediable mean? So part of, I would say, a significant criticism over the legislation generally is that some of these terms are quite vague. And so the definitions of them are somewhat open to interpretation. So in different places, not in the Canadian context, for physician-assisted suicide, you may need to have a diagnosis with you've got 6 months to live, like it's a terminal diagnosis, and there is a stringent criteria for it. Now, the arguments against that are that, well, determining months is an estimate. It's not really a concrete amount. And so you could be either excluding people or including people that you ought not to be given specific time frames. Canada, we don't have that, but it's just important to note that different places actually do this framework quite differently. So grievous and irremediable is defined as having a serious illness, disease, or disability, and it has to be in an advanced state of decline, which is irreversible. So it cannot be reversed. And then the last is this language, and I'm going to read it off, but experience unbearable physical or mental suffering from your illness, disease, disability, or state of decline that cannot be relieved under conditions that you consider acceptable. Okay? Which is also quite vague, right? Because that's very individualistic of what you consider acceptable is different than maybe what I consider acceptable, etc. It's also important to note that natural death is technically foreseeable, reasonably foreseeable, but there's no specific timeline, and it also doesn't need to be a fatal or technically terminal condition. So I guess now it's probably been maybe a year and a half, 2 years ago, there was a woman who petitioned because she was excluded from medical assistance in dying due to her Parkinson's, because technically it was not fatal, and technically it is not terminal. But it was irremediable in the sense of, like, she wasn't going to get better, she was going to continue status quo or decline, and she petitioned because she was initially excluded, and then she was permitted. So it is quite vague, actually, even what this means given the language. So one aspect is you have to have appropriate informed consent for MAID. So you have to be given information about the following categories: your medical diagnosis, available forms of treatment, available forms to relieve your suffering. Interesting that it's called suffering is the terminology that's in there, including palliative care. Okay, so they don't talk about pain management per se, but they do talk about suffering. And you are supposed to be aware of your palliative care options. So an aspect that still hasn't been completely parsed out, and there has been, in December of 2018, there was more of a call for, could you actually have MAID as part of advanced care planning? So like it would be a portion in advanced care directives. Could those who are suffering from mental illness be more eligible for MAID? And that hasn't been quite clearly laid out at all. And then the question became about mature minors as well. So those were 3 other areas and categories that are kind of under review and assessment at this time. But mental illness and disability, you technically may be eligible for medical assistance in dying if your natural death is, 1, foreseeable, and you're able to make medical decisions. So it's a little bit unclear as to exactly what that category is. But simply because you have a mental illness or disability doesn't make you ineligible for medical assistance in dying. So the process that's in place, in theory, is that you submit a written request as a patient. If you can't submit a written request, then someone has to make a written request on your behalf. So that person, for example, could be your healthcare proxy. That person writes the request. They have to be above the age of 18. They have to understand what medical assistance in dying is. They cannot benefit from your death, and it needs to be signed by 2 witnesses. So it's unlikely technically to be your healthcare proxy for a lot of reasons. So, for example, if you appoint a child as your healthcare proxy, chances are if you die, they will inherit your debts and your assets, right? So there's some quote-unquote benefit, financial benefit from your passing. They're unlikely to be eligible as a person who could sign. So this is almost like a third party, a medical practitioner, someone else who would actually help you with the written request. So the assessment process. So after a patient has asked for information regarding MAID, they've gone through the written request process, then what happens is you are assessed to see whether or not you fit under those eligibility requirements that we just talked about. So in Manitoba, there is an assessment team. That team goes to different facilities and does the assessment of whether a patient is eligible. So within that team, a physician or nurse practitioner can determine whether you're eligible, and then a second physician or nurse practitioner must also provide a written opinion about eligibility, and they need to be independent assessments, which means like no one can benefit from your death, and also there is supposed to not be any sort of like hierarchy. So for example, your medical director, and then you're under the medical director and you're feeling pressure that you would have to agree with the medical director. It's meant to be impartial opinions, and you cannot be like objectively connected with one another. Yes?
Does the second physician know what the first physician's recommendations were?
That is a good question. I don't think there's any requirement that they not know or do know. Yeah, I don't think there's any requirement that they not know or do know. I'd have to check, though. I don't know off the top of my head, but that's a good question. So the process. So after you have been deemed eligible, there is, in theory, a 10-day waiting period where you have time to really consider it. However, that time period can actually be shrunk depending on whether there's concern about the patient losing capacity within that 10-day period. So before MAID is actually administered, there is a secondary consent that happens again. So you've been given the assessment, you're saying you would like medical assistance in dying, 10 days go by. When it actually comes to the day of, then there's and really the moments before, there's another ask of whether or not you would like medical assistance in dying. But sometimes within that 10-day period, that person may no longer have decision-making capacity. So the 10-day window, depending on the circumstance, actually becomes smaller. Importantly, you may withdraw a request at any time. So just because you have signed an informed consent form, because you've made verbal consent, you've agreed to this process, you do not actually have to undergo medical assistance in dying. So this is interesting kind of from a St. Boniface perspective. So at St. Boniface Hospital, because it is a Catholic healthcare organization, medical assistance in dying is not done at St. B. MAID is done primarily in Manitoba at HSC and at Deer Lodge. Those are really the 2 facilities in which it is done in Winnipeg. But what ends up happening is that a person, if they're in St. Boniface Hospital and they ask for MAID, the MAID assessment team will come to St. B, they will do the assessment, and then that patient is transferred to HSC or Deer Lodge. In theory, what could happen is if that patient would go to HSC, and at that point they've declined MAID, they have the ability to come back to St. Boniface to continue receiving medical interventions. I've been told that that has never happened. So once someone has agreed and they've gone to HSC or Deer Lodge, there hasn't been a change in opinion. They haven't come back to St. B. So how is it actually administered in Manitoba? Right now, we only have medical practitioner and nurse practitioner. It's the direct administration. It's not that I get a prescription and go home and commit suicide at home. It's that this is actually done within healthcare facilities. Technically, under the definition, there has been reserved a right that, in theory, it could become self-administration. So The argument for self-administration, and the reason why this is actually passed, assisted suicide is passed in other places, is that there is this want to die at home versus wanting to die kind of within a healthcare facility. So people then would get a prescription, they'll choose to fill it or not, they go home, and then they choose to consume the medications or not. But often it's tied with this desire to die at home. That's often kind of a lot of the conversations within that. So obviously this is a very politically divisive issue. There's a lot of ethics surrounding it, but kind of the two groups of viewpoints are most arguments for medical assistance in dying focus on patient autonomy. So this is a person's right, based upon their own values, philosophical, religious, or otherwise, to make a decision regarding ending their life. Okay, that's really where kind of the one camp is. The other camp is concerned about consent concerns, coercion, undue influence, and then aside from that, also kind of morality questions about ending one's life earlier than natural death. And so those are really the two kind of groups when we think about polar opposites associated with medical assistance in dying. So to parse out the autonomy argument, essentially, as we talked about earlier this morning, it's the ability for an individual to make preferences based upon their value-laden beliefs. They decide for themselves that they no longer want to live. They have an informed consent process, they sign the necessary paperwork, you've got 10 days of waiting, etc. And so the argument is that, well, I decide to do this. Now, there are a lot of these other questions associated with assistance of others in your death. So conscientious objection, concerns about administration. So it's different than a person going home and committing suicide. There is now third parties who are involved in the aiding and abetting of the process of your death. And so for the autonomy argument, there's also a concern about conscientious objection and involving parties that may not want to be involved. Which the workaround for that right now is that there is a MAID team. So the MAID team essentially deals with that. That allows care practitioners who don't want to be involved or not involved with the process. So the other aspect of this is more kind of relative ethics and relativism and somewhat of kind of apathy as well. So there's this aspect of philosophical ethics that are based in different frameworks. So utilitarianism, which is really focused on the greatest amount of benefit for the greatest amount of people. Consequentialism, which focuses on the consequences of arguments. There's natural law, which is this idea of kind of a natural ordering and how things ought to be based upon often a higher power. It doesn't have to be God, it can be a philosophical power. There are a lot of different aspects with different frameworks that people use, deontology, etc. Relativism is the one that I think is most important when we're thinking about some of these more politically divisive questions, because a lot of people, and I'm sure many are here and many of them are kind of just in the other room over there, it's this idea that, well, if it doesn't affect me, but it affects other people and they want that decision, and it doesn't affect me, other people ought to be able to make decisions. Okay? And so it's this idea of kind of relativism of, well, society holds that I as a person get to make decisions in X circumstances, so therefore I should be able to make decisions in Y circumstances. And so it's a little bit, the Canadian framework on that is a little bit different, where I find people when we talk about MAID, there are some who are in the two camps of, I think MAID is wrong, I think MAID is a right, but then there's a lot of people who are, well, I wouldn't want medical assistance in dying, but if somebody else wants medical assistance in dying, they ought to be able to get it. And so that falls into a lot of this conversation about relativism and kind of relative ethics and the political framework. Yes?
I just wanted to make a point that, it's very informative.
It's important to parse it out that palliative care is a form of medical treatment, medical options, kind of a individualistic approach of feeding interventions, whether you're at home, in a facility, how you're supported. MAID is a different decision, a different choice. That's not, you don't have to be in a palliative care quote-unquote program in order for MAID to be an option. So you can be a person who has a different illness or disease, and then they can elect MAID without going through palliative care as well. And they're often, you are right, they're often talked about, especially from an educational perspective, in one. From a practicality perspective, it would really depend on practitioners, who's actually having the conversations. My experience is that it's not offered like a menu option. Like it's not, here's palliative care options, and if you don't want to engage in palliative care options, here's medical assistance in dying. Like it's not offered that way. However, that's not to say that it hasn't been offered that way at some point. But it's usually patient-driven at this point in time. It's usually the patient is saying, I would like medical assistance in dying. It's important to note, though, some patients are not necessarily, I want medical assistance in dying. It's, I no longer want to live. And so does that trigger then a request for MAID? And so the triggering aspect for information is not as clear, for sure. Okay. So it's important to think about these concepts when we talk about when there is an intended consequence and when there is a foreseeable consequence. And so a good kind of framework for a lot of philosophical teaching, not just Catholic teaching, is this notion of double effect. So double effect was initially really written about by a philosopher named Elizabeth Anscombe, and she wrote a lot on double effect, kind of how the framework ought to work. And the idea is that there are certain actions in life, particularly certain medical interventions, that are going to have a benefit but are also going to have a consequence. And so it's sometimes impossible to avoid that consequence. And so what happens when you are kind of stuck in that dichotomy? So, for example, terminating an ectopic pregnancy because it's a severe risk to the life of the mother. And so the consequence, unfortunately, is the death of the growing fetus. The benefit, though, is that the woman's health is preserved at that time. So there are certain circumstances where we're stuck. The outcomes are not, there's going to be a negative outcome. So what do we actually do in those circumstances? And so then the question becomes, does MAID actually end suffering? And we'll talk about that in a moment. So the conditions for double effect, these are actually nicely written in something called the Healthcare Ethics Guide. But the Healthcare Ethics Guide focuses on these conditions. So first off, the action of the person has to be morally good or neutral. So for example, in the termination concept, it's neutral. It's neutral to good. We're saving the life of the mother. So it's not a bad thing, right? Saving the life of the mother is not a bad thing. We can objectively state that saving her life is a good thing. And there are two anticipated outcomes. The one outcome is that she's going to live. The other outcome is that the developing embryo fetus is not going to live. Okay, those are the two anticipated outcomes. The harmful effect, so the termination of the developing embryo is not really the sole means of the good. So the end in this situation is that the woman has reduced her risk that she's going to live. And it also needs to be proportionate. So, for example, you can't, it's this proportionality argument where it can't be so bad or so good, like it needs to be relative to one another. So in this case, we're stuck. So the pregnancy, if it develops, is unlikely to be successful for the fetus and is at a very high risk for the woman. And so we've got these two aspects. And the last is there's not like another solution. In this case, there's no other alternative. We're really stuck in that situation. And so this framework basically permits the determination of the ectopic pregnancy. And the reason why I'm using more of the pregnancy aspect is that when we use a concept like this in kind of palliative options, the idea of medication kind of hastening death, we've actually advanced quite a lot in palliative care options, and so those medications don't actually have the same effect that they used to. We're much better at managing it. So the clear example is looking more in kind of the termination of pregnancy. Now, this doesn't actually apply for medical assistance in dying, because the sole purpose of medical assistance in dying is to result in death. So we talk about intentionality a lot in Catholic ethics and Catholic moral teachings, where what is the actual intention? So in this framework, with the termination of pregnancy, the intention is to save the mother's life. The secondary consequence is the death of the developing fetus. With MAID, the intention is to cause death. There's not a secondary aspect to it. The intention itself is death. Now, some may argue that the intention is to alleviate suffering, and the consequence is death, but actual ending of life, like the actual end of life, doesn't really end suffering. It just ends life. So it's important to parse that out when we think about this. Now, this is not to say that there isn't circumstances in which we're not good at managing pain management, we're not good at quality of life for certain people. There are certain aspects of palliative sedation where people get to a point where they're so ill that the only way to actually manage pain is to sedate them. But MAID itself does not fall under kind of this framework of what is the actual intention. The intention is to end the person's life. And this really focuses on this idea of, and it's a strong theme in Catholic moral teaching, but that we preserve human dignity and life from the moment of conception to the moment of natural death. And so this is where all of this falls under. It's that there is this framework of life, and that we preserve life throughout, but we don't interfere or end life prematurely. Okay, any questions?
You were talking
Yes, go ahead.
You just mentioned about giving medication.
Yes.
Actually, that happened to my sister in Saskatchewan. She was in such pain, they didn't have a palliative care bed for her.
Mm-hmm.
They didn't manage her pain well.
Yep.
They eventually just said, well, put me out, you know.
Yep.
So they basically did. They put her out completely in a coma until she died of natural death. So
Yeah.
Could you kind of talk around that?
Yeah, of course. So palliative sedation, there are different protocols, and there's different requirements and what is the underlying condition that's causing pain. And typically palliative sedation is the last option. So we've gone through absolutely every option to try to manage pain. And if we cannot, and it's looking as if natural death is going to happen within a short period of time, then some physicians will move to palliative sedation. And the reasoning is that we don't like to sedate people unless there's a need to sedate people. But if you are experiencing such unbearable pain that we're not able to manage it with any sort of medications, other assists, that at some point no longer being conscious can actually relieve that pain. And so we typically do that, I would say 3 to 4 days before the end of life. It's not always that case, but palliative sedation is the last resort for pain management.
So that actually...
It happens, yeah.
That's acceptable in our Catholic faith, isn't it?
Yes, for sure. Because the idea is that it's a palliative option, and it's providing the most amount of comfort to a person, and it's also not, the intention is not to end the person's life. The intention is to manage their pain, and the secondary consequence is that they're not conscious anymore. There's always, I think, this concern with palliative care and pain management of, is this going to hasten someone's death? And is that too much medication? Did we kill them because we gave them too much medication? Palliative care and pain management has come a long way, and we're very, very good at managing people's pain and keeping their respiratory rates up and making sure that they're alive. So it's not as much of a concern, but it does focus on the fact that the intention is to manage pain, not cause death.
Does that palliative sedation sometimes last longer than
It can.
3 or 4 days?
It can, for sure. It can. It's a clinical decision. I often see it in the 3 to 4 days because, to be honest, when it happens, some patients are sedate me, absolutely. But some are managing this, I want to be able to engage with my family and then pain. So it's I'm going to hold out as long as possible because I want to be able to engage, but at some point it just becomes unbearable and then sedation ends up happening.
when we speak of safeguards, and we always hear about safeguards when governments decide to accept MAID and self-infliction of death, we always talk about safeguards. But if you look at the safeguards here in Canada, you see that it's nearly wide open.
Yep.
It's nearly wide open. It doesn't say that it's wide open to all kinds of abuses. So I'm glad I'm here today because I found your presentation very, very good.
Thank you.
Thank you very much, and I think you've enlightened a lot of us about a lot of things. And I certainly wish that we will continue to have things like that. And please talk to your neighbors and your
families.
and family and all kinds of things about how interesting this session was and how important it is to go to a session like this. So that's...
Thank you.
I just have a question. I'm wondering if you can clarify. We talked about healthcare proxies before, and I'm just wondering if there can be the situation where somebody can have a healthcare proxy and then independently decide that they wish to receive MAID.
So,
Can the consent and desire for MAID supersede the proxy?
so when someone is wanting to get medical assistance in dying right now, they have to have decision-making capacity to engage in it. So the proxy is not at all involved. There is a question, though, about whether this could be done with advanced care planning, and so that a person could know that they would like to receive medical assistance in dying given whatever circumstance, just like we talked about CPR, dialysis, etc. And then in theory, a healthcare proxy would then be able to advocate based upon that noted preference. At this point in time, that's not an option, but there has been this general conversation of whether medical assistance in dying could be something that's added in advanced care planning.
I'd just like to know what would, if you die through MAID, what do they put on your cause of death, on the death?
It's a good question, and it's a very good question. Right now, it's actually listed as natural cause. So it's a very good question. I think so. Globally, aside from like our personal responses to it, I think globally we need to set better expectations about actually what is a good death and what is pain management and what does death look like. I think that we have in our head this idea of dying at home amongst our loved ones. Comfortable is kind of how we all want to go, right? I think, oh yeah, being 95 and asleep and not waking up seems like a peaceful way, but that's not how people actually end up dying. And so, kind of reframing that and setting this expectation too of we're going to be able to manage some of your pain. We're not going to be able to manage all of your pain. So there is a level of pain that you will live with. And so I think when we say palliative, sometimes we think, oh, pain-free. But that's not necessarily the case. When we have conversations with family and friends, I like to think of people that are in kind of the different camps. So you've got people who are consistently opposed to MAID. It doesn't have to be like philosophical or religious preference, they're just opposed to it. You've got the people who are for it and believe that not only would I want medical assistance in dying, but I think everyone should have the option. I think most people are in between. They're in the, well, I don't really think I would want it, but if somebody else wants it, I shouldn't infringe upon that. Or I'm not in that circumstance, so therefore I don't know how I would want to die, or I wouldn't want to live like that. I think those are the vast majority of people fall within that category. And those are the people that you can actually dialogue with. The people who are in the other two camps sometimes are not great at conversation, not great at dialoguing, because they're just, this is my belief, this is a belief that you should have, the end. Some are very good at dialoguing about it. The in-between, I would really have strong conversations about what is the actual rationale. So I think a lot of this has to deal with burdens. People don't want to be burdens. People don't want to be burdens to their families, friends, society, financially, all of it. Also, people are alone. A lot of people are alone at the end of life. And we can't fix the aloneness problem per se. But I think if that's the fear, if the fear is dying alone and dying in pain, that's an easier fix. You can build a support system. You can have those conversations. But to me, it's why is it that people view it the way that they do? And sometimes it's fear. And if it's fear, then I think the biggest thing to do is fear is, some of it is rational and some of it is completely irrational. And you can try to address some of more of the concrete concerns of, well, I would be here with you, I would support you, I would be an advocate for you, and that you're not going to be dying alone and in unbelievable pain. And there's also an aspect too, it's not just physiological pain, right? So there is a lot of psychological aspects with it, traumas, losses, depression, concerns. There's a lot of other concerns that are not just physiological responses, but still actually trigger a physiological pain too. So there's also that aspect as well. I have concerns generally about speeding up any process, partly because if you're just doing something for the potential future consequence, it seems as though that can be a pressure in and of itself. So if I'm worried that I'm going to lose capacity, I got to get this done now, maybe I'm not having enough time to fully reflect upon something. And it's not just in the MAID situation either. Like, anytime decisions are made in emergent circumstances, it's not the best decision making because you haven't had really time to process, time to think about all of the other consequences. So the shortening concerns me, but it doesn't concern me just in the MAID context. It concerns me in all contexts. Okay, so I struggle with the terminology like pulling the plug because we talk about it a lot, and this goes back to the withdrawal of care or withdrawal of medical interventions or kind of staying medical interventions. I think when we think pulling the plug per se, we think removing a ventilation and removing of like cardiovascular support. I think that's kind of what we think about. This goes back to like the ordinary versus kind of extraordinary means of ventilation. So if you are put on ventilation support for a period of time, thinking that there's likely a benefit, that there's a chance of improvement, that you are going to get better, then we are morally obligated to provide ventilation support. The question then becomes, well, okay, if I am on ventilated support, for how long? So there are so many factors that play into that. So there are different supports. There's like air oxygen via like a mask, nasal, something called Optiflow, which is high-level oxygen via a mask. Then there's intubation, in which there's a tube down your throat. And that lasts, usually they don't like it to be intubated more than 2 to 3 weeks due to risk of infection. Past that, you move to something called a tracheostomy, which puts essentially support through your trach. And that's a long-term, basically, vent support option. Now, there are people who are fully capacitated, who need to be on trach support, and will live several years on trach support. It's what happens when you are intubated past that 2 to 3 week mark of, are we going to be moving to long-term ventilated support, or are we going to move to withdrawing that support and allowing natural death? There are so many other factors that play into that. So if you are a person, for all intensive purposes, everything else in your body is working fine except for ventilation, on the balance scale, we move towards ventilation. If you are in multi-organ failure and you've got cancer or an underlying infection and you are unlikely to have any sort of benefit, then the ventilation is no longer the main source of really helping you improve. It's just keeping you alive for that period of time. So it's really this question of, does that ventilation actually have some sort of benefit? Is there going to be a future benefit? Or is it just at that moment prolonging the inevitable natural death? It's really, and so that's why it's when we say pull the plug, there are so many other factors that play into it where I can't say to you, yes, vent is okay, vent not okay. Where this conversation often happens is at that moment when we're moving from being intubated to either tracheostomy or different support, or extubation, moving towards more palliative options.
How's your brain doing?
Oh, okay. So if you're brain dead, if you're actually legally brain dead, that's a different circumstance. Where we end up in this kind of gray area is where it's something called like a global anoxic brain injury. So you've been down, you haven't had air support, the blood has not been oxygenated, so your brain essentially has died in a lot of ways. Now, you may have like lower brainstem function, you may have some sort of brain function, and then this becomes this, well, what do we do in those circumstances? There is, again, not really like a concrete answer, but if you've got a global anoxic brain injury, you're not engaging, there's no chance of improvement, and the only thing that is happening is that you've been supported by a vent. We are just prolonging death at that point. And so removing the vent and moving to palliative options would be perfectly fine. The problem, though, is these brain injuries can vary in severity. And so you may have a small anoxic brain injury, and maybe there's a chance of some recovery. You may have a massive one in which there's virtually no chance. This isn't to say, though, if your preference was, I want to stay on ventilation support and I want to, these are my preferences, we abide by those preferences. There is always a somewhat question of futility and respect for human dignity and the body. When you're at that point, if you've had a really massive global anoxic brain injury, poking and prodding the body also becomes, is this actually preserving your human dignity too? If you're sitting there and you're not engaging and we're taking your blood constantly and you've got tubes in every aspect of your body, there's no right or wrong answer, but moving to comfort would be fine in those circumstances. So there's a long history on kind of criteria for brain death, criteria for cardiac death, criteria for like organ donation, etc. There is legal brain death. At that point, it provides us the opportunity, for example, to undergo organ donation, etc. That doesn't mean that you're obligated to. So just because you've hit brain death doesn't mean that you're going to be obligated to undergo organ donation. Generally, if you've hit a legal framework of brain death, we're done on the medical intervention standpoint. That doesn't say that circumstances like that could not happen, but from a medical intervention, brain death is the current kind of criteria.
But how do they measure brain death?
There's a lot of factors, but they do brain scans, they do electrical activity in the brain, and if nothing comes, like if there's absolutely no activity, no reflexes, no any sort of engagement, and they do multiple tests over and over again, and they do a waiting period, and if it comes back constantly that there isn't, then the person is then being determined to have brain death. Yeah. Yes.
I know some people have to go, so I'm just going to say just a couple of things. I hope everybody enjoyed their time here today.